Welcome to the deep dive. Okay, for those of you tackling the MSRA, today we're really zeroing in on Smith's fracture, using your revision notes as our guide.
Absolutely. Think of this as your high-yield summary. Our aim is to make Smith's fracture stick in your mind.
Exactly. Crystal clear for rapid recall. So let's get straight into it. Definition first, what exactly is a Smith's fracture?
Okay, so fundamentally, it's a fracture of the distal radius. That's the end of the main forearm bone near your wrist.
Right, the radius.
And the key feature is that the broken piece, the distal fragment, it actually shifts forwards, towards the palm side.
Forwards. Volar displacement.
That's the term, volar displacement. It often creates a specific look described as a garden spade deformity.
Garden spade. Got it. And it's sometimes called a reverse Colles fracture.
Precisely, because in a Colles fracture, the fragment goes backwards, dorsally. Smith's is the mirror image, it goes forwards, volarly.
Okay, that makes sense. Reverse Colles. So how does this typically happen, the mechanism?
It's usually from a fall, but specifically falling backwards onto a flexed wrist. So the palm hits the ground.
Ah, okay. Flexed wrist, impact on the palm.
Yes. That force drives the distal fragment anteriorly.
And on an X-ray, that's the dead giveaway.
That's the main thing you're looking for, that anterior or volar displacement of the distal radius fragment, completely opposite to Colles.
Are there different types?
Yes. We classify them. Type I is extra-articular, meaning outside the joint. Type 2 goes into the joint, intra-articular. And type 3 involves a fractured dislocation of the radiocarpal joint.
Right. And you mentioned it's similar to Colles in some ways.
Yeah, interestingly, the ways we reduce the fracture, put it back in place, and the kinds of complications you might see, they often echo what happens with Colles' fractures.
Okay, so main cause is that specific fall. Are there other risk factors that make someone more susceptible?
Definitely. Things like repetitive wrist movements could play a role. Anything that increases your risk of falls, generally.
Like balance issues.
Exactly. And also conditions that weaken the bones themselves, like osteoporosis, makes the bone more likely to break under that force.
Makes sense. Can you walk us through the pathophysiology, what's happening structurally?
So you've got this force disrupting the integrity of the distal radius. The fracture line itself is often transverse, straight across, or maybe a bit oblique.
Okay.
And it extends towards the palm side, the volar aspect. That forward shift of the distal piece is what causes that visible garden spade shape we talked about.
Right. So if you suspect a wrist fracture, what else should be on your differential list besides Smith's?
Good question. You obviously need to differentiate it from Colles, that's number one, based on displacement direction.
Okay.
But also consider other wrist fractures, maybe a scaphoid fracture, especially if there's pain in the anatomical snuff box, or an ulnar styloid fracture on the pinky finger side of the wrist.
How common is Smith's compared to, say, Colles?
It's definitely less common. Colles fractures are seen much more frequently. We don't have super precise UK prevalence data, but the general understanding is a lower incidence for Smith's.
So when a patient comes in, what clinical features shout Smith's fracture?
Well, pain and swelling are pretty standard for any fracture, but the key visual clue is that deformity, the garden spade look, or that obvious volar tilt of the wrist.
And functionally.
They'll have limited wrist and hand motion, definite tenderness over the fracture site, and probably bruising showing up too. It significantly impairs their hand function.
And confirmation comes from imaging.
Yes. Standard wrist x-rays are usually sufficient. You need AP, so front to back, and lateral side-on views. That shows the fracture and that crucial anterior displacement.
Any role for CT or MRI?
Sometimes, if it's a really complex fracture pattern, maybe going into the joint significantly, or if you're worried about associated ligament damage, then a CT or MRI can give much more detail.
Right. Let's talk management. How do we approach treatment?
It's tailored, really. Depends on the fracture's characteristics, how displaced it is, whether it's stable, if it involves the joint and patient factors too, like age and activity level.
What are the options?
For less severe cases, fractures that aren't badly displaced or are stable, conservative management works. That means immobilization in a cast or a splint, plus pain control and regular follow-up x-rays.
And for the more serious ones?
If there's significant displacement, instability, or joint involvement, then surgery is often the way to go. Usually involves open reduction and internal fixation using plates and screws to hold the bone fragments in the correct position while they heal.
What's the outlook generally, the prognosis?
Generally quite good, especially with appropriate and timely treatment.
How long does healing take?
Healing itself takes several weeks, maybe a few months, but regaining full function relies heavily on rehabilitation. Physiotherapy is absolutely key.
Are there things that influence that outcome?
Yes. Age is a factor, the severity of the initial fracture, any associated injuries, and importantly, how well the patient engages with the rehab plan. Compliance makes a big difference.
And are there potential pitfalls, complications?
There are, yes. Like any fracture, malunion is one where the bone heals but in the wrong position, which can affect function and appearance.
Okay.
Non-union, where it fails to heal altogether, though that's less common. Stiffness is a big one after immobilization. Nerve damage, like to the median nerve, or even blood vessel injury can occur. Longer term, there's a risk of osteoarthritis in the wrist joint, and some people might develop chronic pain.
How do we try and avoid those?
The best prevention is accurate reduction, statal fixation if surgery is needed, appropriate immobilization, prompt recognition of any issues during follow-up, and really diligent rehabilitation.
Great. So quick recap for MSRA revision. Smith's fractured distal radius break, anterior or volar displacement of the distal fragment. Think garden spade deformity. It's the reverse of Colles, usually caused by falling backwards onto a flexed wrist.
Exactly. Key differentiator is that anterior displacement on the lateral X-ray.
Diagnosis mainly via X-ray. Management is either conservative with a cast for stable fractures or surgical fixation for unstable or displaced ones.
And remember the importance of physiotherapy for regaining function. Prognosis is generally good, but watch out for complications like malunion, stiffness, and nerve issues.
Perfect summary. Keep those key points locked in.
You've got this.
And for more fantastic resources to help smash your MSRA revision, definitely check out PassThemSRA.com and also FreeSRA.com. Loads of great material there.
Highly recommended.
Thanks for joining us for this deep dive.